We covered the three major risk factors, which were blood pressure, keeping that in check, don't smoke, and ApoB. And we've now talked about the things to adjust ApoB levels. We did not really talk about things to adjust blood pressure. I'm assuming exercise sits as one of the foremost.
Exercise, nutrition. Yeah, weight management is a huge one here. So, you take a person who's blood, and this is one of those things where we don't immediately jump on the pharmacotherapy train with blood pressure, because here there are side effects sometimes. And you do have to worry about overshooting. You don't really have to worry about overshooting a person's lipids. We do back off if we overshoot, but it doesn't cause a symptom. There's not a short-term immediate risk from doing that. If you overshoot somebody's blood pressure medication, you trade one problem for another problem. They become lightheaded when they get up to pee at night. They fall and bang their head. That's a devastating consequence. Totally unacceptable. So our goal is to see how much we can lower blood pressure without medication before we turn to medication. And let's be clear, the meds today are so much better than they used to be. Again, there was a day when the side effects of these medicines were miserable. That's simply not the case today. I mean, ACE inhibitors, angiotensin receptor blockers, these things are very well tolerated, especially the ARBs. So again, almost anybody can be on these things. But if we could get a person to lose 10 pounds and exercise every day, we see great effects with zone 2 stuff, right? So kind of the low intensity cardio.
And your recommendation there? I know you talk about this in the book, but I've thrown out numbers about 150 to 180 minutes per week. You go a bit higher.
Yeah, we go 180 to 250, 240. Yeah, I'd like to see 3 to 4 hours a week of zone 2. So that's an important piece, and sleep is an important piece. So get the sleep right, get the exercise right. If you're overnourished, let's correct that problem. And if all of that doesn't work, and by the way, that works a lot of the time. That works most of the time. If that doesn't work, then we've got pharmacotherapy. There is still a true phenomenon of essential hypertension, which is in individuals for whom all the fixable stuff has been fixed and they still have high blood pressure. We still have to medicate those folks. By the way, there's something that I want to mention here that doesn't get much attention, but it's so important, which is the effect of high blood pressure on the kidney and also the brain itself. We've talked about the brain, we've talked about the heart, but the kidney doesn't get enough attention. The kidney is a remarkable organ. And I think if you're really in this game of trying to live longer, right? If you think, hey, maybe we'll live 80, 85 years, but if we kind of start doing all of these other things and really optimizing our behaviors, that could be 95. Well, you have to start thinking about the capacity of the kidney. And once the glomerular filtration rate falls below a certain level, you have to be very careful with how you live your life. And unfortunately, this is one of those things that is another sort of mistake that's made in kind of modern medicine, which is we don't pay enough attention to how to measure kidney function correctly. We rely very heavily on something called creatinine, as opposed to looking at another biomarker called cystatin C, which is far more accurate. And we also tolerate too low of a kidney function for a person's age. So we look at, we might look at someone who's 50, whose kidney function is at 65% and say, you're totally fine. Because it's true that at 65%, there is no problem. But you're not thinking, well, if this person has to live another 40 years and this continues to go down, they're going to potentially be staring down the barrel of needing dialysis the last 5 years of their life. Again, you want to die with compromised kidney function, but never from compromised kidney function. In fact, the hazard ratio of all-cause mortality associated with compromised kidney function is even greater than that of heart disease. Once you cross that threshold, lights out. Once you are needing dialysis, your risk of death is higher than that of someone with high blood pressure, smoking, even someone who has cancer. You have a higher risk of death having end-stage renal disease than you do having cancer. So the kidney is so sensitive to blood pressure. This is a tiny organ that on every pump of your heart is getting 20 to 25% of your blood.
Wow.
So just imagine how sensitive and susceptible it is to elevated blood pressure.
We've covered quite a few corners of avoiding the major killer, atherosclerosis. Let's talk about cancer. Nobody wants cancer. Everybody seems to know somebody who has had or has died of cancer. and probably no surprise given that it's number 2 on the list. What are the numbers, and what can people do to offset cancer? And of course, there are a huge number of different types of cancer. And inside of this conversation, I just want to earmark that might be good to have a conversation about alcohol, which we didn't talk about in the last discussion. But if alcohol is involved, or is a risk factor rather, for cardiovascular disease or cerebrovascular disease, now would probably be the time to mention it.
Yeah, this has been looked at in a number of ways, so if you look at sort of top line epidemiology, and you've heard of these things called the French paradox, which is, oh, come on, like they eat all of this fatty stuff and drink all this wine, and they have a slightly lower risk of cardiovascular disease. You just have to kind of throw that stuff out the window because there's so many confounders there that it's kind of useless epidemiology. If you really look at the data clearly, and there was actually a really elegant analysis that included some genetic studies that came out in JAMA about a year ago, it's actually pretty clear that there is no dose of ethanol that is healthy. Okay, so there's no J curve. So there used to be kind of this literature that said there's a J curve associated with ethanol. So meaning at total abstinence, there's a slightly higher risk of death than if you're drinking 1 drink a day. And then if you go beyond 1 drink a day, the rate of death starts to climb. The problem with that analysis, so there's just been a lot of consternation around that. But the problem with those analyses are multiple. But the most important of these are that the abstainers have a reason for abstaining typically. And those reasons can't be extracted statistically from these analyses. So I'll leave it at that I've written many blog posts about this. If people are really interested, they can go and talk about that. I also do talk about this a little bit in the book, by the way. But the short answer is there is no dose of ethanol that is healthy. I would argue that it's not a straight line of risk, but it probably goes, I think from 0 to 1, there's probably no measurable harm for most people.
1 per day or 1 per week?
Probably 1 per day, up to 1 per day. It's probably very difficult to discern the harm, but I'm going to put a caveat on that I'll come back to. And then I think the risk starts to climb pretty steeply after that. And I think it climbs non-linearly after that. That is my reading of the literature. Okay. So then how do you decide if you're going to have up to 1 drink a day? And by the way, that's not the same as 7 a week, because that doesn't mean 7 in a day.
Right. Which we know is really detrimental.
Right.
Especially for the brain.
Right.
But also the cascades that result from disrupted sleep, not just for that one night, but multiple nights.
Yep.
Yeah. The literature I've seen on alcohol, that the most, now again, this is an emerging literature because what you're describing is exactly right. But people are now, some more conservative folks are starting to place it at 2 drinks per week total, beyond which you start running into issues, especially for women in terms of breast cancer risk, which is something maybe we can circle back on.
Yeah, I mean, look, my view is if you can not drink at all, you're better off not drinking at all. And people always say to me, well, Peter, what's your view on this? And my view is I do drink. I'll go weeks at a time without having a drink. I haven't had a drink, I've had 1 drink since I saw you last a couple of weeks ago because I've been sick. So I'm thinking, well, gosh, like the deck is stacked against me right now. Why would I do anything to stack it more? But my philosophy, which is half tongue in cheek, but is true, is like, I just don't drink bad alcohol. I sort of, my wife saw me do this the other day. We opened up a bottle of wine, and it was a very expensive bottle of wine. And I took a sip and I was like, yeah, I just dumped my glass. I was like, I don't know, it just doesn't taste right to me. And it tasted fine to her. So I don't think it was that the wine had spoiled. It was just, I didn't like the taste of it enough to justify drinking it. I was like, I don't feel like drinking it.
Yeah. I'm fortunate that there were times in life, certainly college and portions of graduate school when I drank, but I've never really enjoyed the taste or experience of alcohol. So all the alcohol on the planet could disappear. I wouldn't even notice, but I'll have one every once in a while. I'm sort of that mindset. But great to hear that 0 is better than any, because I think everyone agrees on that. So it doesn't appear that alcohol can be directly linked to cardiovascular disease and cerebrovascular disease. Although there
Well,
are these indirect effects through insulin,
Yeah, I was
altering
about to say,
insulin sensitivity,
and through sleep,
right? And
right?
through sleep.
I think the impact of sleep on cardiovascular cerebrovascular disease is profound, and I do think that the impact of ethanol on sleep is underappreciated.
Yeah, and here I think we should do a little nod to Matt Walker, the great Matt Walker, because 10 years ago, if someone had a conversation about sleep and how critical it is, and how not getting enough quality sleep is dangerous, people would have just kind of shake their heads and say, "What's the evidence for that?" I think Matt really deserves most of the credit for alerting people to these issues around not getting enough sleep. It's just remarkable what's happened in the last decade, thanks to Matt.
And while we're on that topic, we have the other next horseman of death, the neurodegenerative diseases. I think those were also heavily impacted, especially on the dementia side, by ethanol. So again, I want to be careful when I say this stuff, right? I don't believe in fear mongering. Okay, I just said a moment ago, I'll say it again. I drink alcohol, and I'm going to continue to drink alcohol, but I think that one has to make the trade-offs, which is like, if I really do love the taste of certain Spanish wines, I really do love the taste of certain tequilas, certain mezcals, and I really do love the taste of certain weird esoteric Belgian beers. And it really does give me pleasure to consume those things in the same way it gives me pleasure to consume certain foods that are quite vapid, right? There's no upside in consuming a brownie that my kid just made, except for the fact that my kid just made it, and it's fun to eat the brownie with them, right? So, we come back to this thing about, like, longevity is also about health span, and part of health span is quality of life. And I write about this in the book, that I think there was a day when my approach to this was purely an engineering approach, which was, we are going to optimize every molecule of my being for this. And if you go so far down that rabbit hole that the quality of your life deteriorates, what's the point? So that's why I think for somebody like you, who says, like, you could take all the alcohol off the face of the earth, I wouldn't even notice, then that's a great reason not to bother drinking. I wouldn't put myself at the opposite end of that spectrum, but I'm probably further to the spectrum, where, yeah, if you told me I could never drink alcohol again, I would be fine with it, but I'd be giving something up that I enjoy. But at the same time, I know if I have 2 drinks with dinner, my sleep sucks. And therefore, that's just a threshold I rarely cross.
Well, I certainly have my vices. Alcohol just doesn't happen to be one of them. What about cancer? Again, nobody wants cancer. We've all known people who have died of cancer or have had cancer. What can be done to reduce one's risk of cancer?
Well, you asked earlier about the numbers, so let's throw some numbers out there, right? So globally, we're talking about 11, 12 million deaths per year, about half the number of ASCVD, still a staggering number. At the individual level, put it this way, somewhere between 1 in 3 and 1 in 4 chance anyone listening to this or watching this is going to get cancer in their lifetime.
But what's the probability they will die from that
Half
cancer?
of that, about a 1 in 6 chance of dying.
Okay, so is it true that every male gets prostate cancer? In other words, on their deathbed,
every man will die with prostate cancer, and some will die from it. You and I have prostate cancer right now.
Thank you for informing me.
Yes. Hopefully we will not die of it. We should not die of it. Prostate cancer, colon cancer are cancers that no one should ever die from, because they're so easy to screen for. They are so easy to treat when they are in their infancy, that it's totally unacceptable that people are dying from this. There are other cancers for which I can't really say that. Breast cancer, much more complicated. Pancreatic cancer, much more complicated. Glioblastoma multiforme, much more complicated. So as you said a second ago, cancer is not a disease. It is a category of diseases. It's not just that each organ is different and breast differs from pancreatic. It's that within breast cancer, ER/PR positive, HER2/neu positive is a totally different disease from the triple negative breast cancers.
Those with BRCA mutations or non-BRCA mutations.
Well, even putting that aside, just looking at the hormone profile of the individual breast cancers, they're totally different diseases. So it's not just that breast cancer is different from prostate cancer, it's that all breast cancers are quite different.
Maybe I should frame the question a little differently then. given the vast number of different types of cancers and categories
well, no,
within
no,
those.
Your question is still a fair one. I just
Okay.
wanted to throw that caveat out there. So now to your question. Okay, so what do we know? It turns out that we can very comfortably speak to several things. One is the role that genes play. So maybe I'll just spend 1 second on a gene 101 thing for the viewer. We want to differentiate between what are called germline mutations and somatic mutations. So your germline and my germline are set. When we were born, our germline mutations, any mutations we have in germline genes are inherited from our parents.
They're non-negotiable.
They're non-negotiable. You got those things. So question one is, how much of cancer results from those types of genetic mutations? And the answer is very little, less than 5%. So now you mentioned one a moment ago, BRCA. Okay, so mutations in BRCA are germline mutations. A woman will get a BRCA mutation from one of her parents. And we will often have a sense of that just from the family history. You know, when mom and sister and aunt and grandmother had breast cancer, you've got a breast cancer gene. Now, it might be BRCA, it might be another gene that's not BRCA, but there's no ambiguity. And we test for these genes, mostly just for insurance purposes, frankly, but there's no ambiguity that that was a germline transmission of a gene that is driving cancer. But 95+% of cancers are not arising from germline mutations. They are arising from somatic mutations or acquired mutations. So the question then becomes, what is driving somatic mutation? And the two clearest indications of drivers of somatic mutation are smoking and obesity. Smoking we've talked about. Let's put that aside for a moment.
I'm so surprised about obesity. I don't know why I'm surprised, but I've never heard this. I'm probably just naive to the literature.
Yeah. So obesity is now the second most prevalent environmental driver of cancer. Now, I will argue, and I think I argue this in the book, hopefully pretty convincingly, I don't think it's obesity per se. I think obesity is just a masquerading proxy. What is obesity? Obesity simply is defined by body mass index. Well, first of all, I don't think I'm obese, but I'm way overweight on BMI. You probably are too. So, let's just acknowledge.
I'm clinically diagnosable as obese.
Are you?
Yeah. Oh no. Well, not clinically.
That would
maybe
be
as
BMI over 30. I don't think you're probably there.
No, but if I measure my weight by height,
yeah. My BMI is probably 27 or 28.
Okay, it's been a little while since I've checked. I only know body fat percentages and things like that.
So basically, like, BMI is a far from perfect proxy, but at the population level, it's what we use. I wish we would get off it, by the way. I think it's really crap
because it doesn't take into account lean versus non-lean tissue.
I think we could get better data if we looked at waist to height ratio. That's a way better metric. So this is just a quick test for everybody. I'm going to argue your BMI is less relevant to me than your eye color. But if your waist circumference is more than 50% of your height, you should be concerned.
Okay, well then I'm okay.
Yeah, you're fine by that metric, right? But that's important. So if you're 6 feet tall, your waist better be under 36 inches. And if it's over, I would argue that's the definition of obesity, not your BMI being over 30. So back to this issue, because we're using such a crude measurement, it basically is catching a whole bunch of stuff. But the question is, what's driving it? And I think if you really look at the physiology of cancer, I don't think it's obesity. I think it's two things that come with obesity. Insulin resistance, which is, 2/3 to 3/4 of obese individuals are insulin resistant, and inflammation. And I think those two things, with the inflammation and the immune dysfunction, with the insulin resistance and the basically tonic growth stimulus that's coming, that's what's driving cancer. So again, is it because a person is storing extra fat, and their love handles that's driving the risk of cancer? No, those are just two things that are coming along for the ride. So beyond those two things, and along with certain, there are also certain environmental toxins we absolutely know are doing this, right? So we understand that people who, have exposure to asbestos have a much higher risk of certain types of lung cancers and things like that. But for the most part, those are our big risks. Beyond that, we talk about alcohol in certain cases. Absolutely. Alcohol is a carcinogen. It's the dose part still isn't clear to me. I don't know, is one drink a day moving the needle much on cancer risk per se? It's not clear.
And it might depend on those genetic predispositions.
Yes. So yeah, if step one is don't get cancer, you have no control over your genes. You have control over smoking. You have control over insulin sensitivity. I wish I could sit here and tell you that there is a proven anti-cancer diet, or that if you do X amount of exercise per week, you're going to not get cancer. We just don't have a fraction of the control over cancer that we have with cardiovascular disease. We don't understand the disease well enough. So we don't understand kind of the initiation process and the propagation process. And we have to rely much more on screening.
Are there good whole body screens for cancer? In other words, can I walk into a tube and or a cylinder rather, and get screened for the presence of tumors any and everywhere in the body outside the brain? Because the brain's a little harder to get to, right?
Believe it or not, the brain is actually pretty easy to screen for.
Because it's so fatty and floating in water.
Well, and also the head, when you put the head into an MRI scanner, there's no movement. It's the least motion artifact is in the brain. So when you use something called diffusion weighted imaging with background subtraction in an MRI, a technology that was actually pioneered in the brain for stroke identification, it's also really good at looking for tumors as well. So let me make the argument for why screening matters, because this is, again, kind of an area where I go far down a rabbit hole in a way that I think traditional medicine would argue against. So my argument for screening is an argument at the individual level, and it goes as follows. To my knowledge, there is not a single example of a cancer that is more effectively treated when the burden of cancer cells in the body is higher than when it is lower. So the two examples I think I talk about in the book are colon cancer and breast cancer. So when you take an individual with stage 4 colon cancer, that means that the cancer has left the colon and is now outside of the colon. So it's usually in the liver at a minimum, potentially in the lungs or in the brain. That person's 5-year survival is very low. Their 10-year survival is 0. We will treat them with a very aggressive regimen of multiple drugs. And again, you'll get a 5-year survival of, maybe 10 to 20%. And by 10 years, nobody's alive. If you take a person with stage 3 colon cancer, so the colon cancer is big and it's even in the lymph nodes around the colon, but at least grossly, you can't see colon cancer cell. You can't see those cells in the liver. Microscopically, of course, we know they're there, because if you don't treat those patients, they still die of colon cancer, but you whack them with the same chemo regimen that you were going to give the metastatic patients, 80% of those people are alive in 5 years. So night and day difference in survival. What's the difference? In the person with metastatic cancer, you're treating a person with hundreds of billions of cells. In the adjuvant setting, which is what we call it adjuvant when you treat people who have only microscopic disease, you're treating billions of cells. The same is true with breast cancer. So we have the clinical trial data to put them side by side. So rule number 1 is don't get cancer. Rule number 2 is catch cancer as early as possible if you're going to get it. Which brings us to your question of how do you screen for it? We basically screen. The first line of screening is imaging, is a sort of visualization. So you have cancers that occur outside the body that you can look at directly. So skin cancer, you can look directly at the skin. Esophageal, gastric, colon cancer, those are outside the body, right? Mouth to anus, embryologically is outside the body. So you can put a scope in and you can look directly at the cancer. But for all other cancers that are inside the body, yeah, you have to rely on some sort of imaging modality. Although now we're starting to look at things called liquid biopsies. So blood tests that are looking for cell-free DNA. And the cell-free DNA gives us a sense of, based on the epigenetic signature of what you're looking at, hey, is there a cancer in the body? And if so, what tissue is it potentially coming from based on these epigenetic signatures? So the problem with relying on any one modality is a problem of sensitivity and specificity optimization. Now, with MRI scanners, which are in some ways the best way to do this because they don't have radiation, so you don't want to be incurring damage as you do this. The irony of doing a whole body CT scan to screen for cancer is a whole body CT scan would be close to 30 to 50 millisieverts of radiation. It's a staggering sum of radiation. So
does that mean that people should, sorry to pull you off this, but I was going to ask about this anyway, avoiding going through the whole body scanner at the airport.
Noise, so low. Yeah, going through a whole body scanner at the airport or even getting a DEXA scan. I mean, these are trivial amounts of radiation.
What about flying? You hear that pilots get more cancer.
Pilots, if you're a pilot who's flying over the North Pole back and forth, you're probably getting 5 to 10 millisieverts a year. The NRC suggests that nobody should get more than 50 millisieverts a year.
So you and I both travel a fair amount, but typical travel for the busy person, let's say 2 round trip flights of more than 2 hours per month and an international trip every 3 months.
Probably still less than a millisievert a year. Yeah. Living at sea level, 1 millisievert a year. Living at a mile elevation, if you lived in Denver, you're at 2 millisieverts a year, basically.
I have to ask, standing in front of the microwave. We've got friends. They ask. And
with or without testes on the counter.
That's an inside joke that unfortunately and fortunately deserves no description. And Peter's not referring to me. But people worry about other sources of radiation. So it doesn't sound like the microwave is a concern. What are the other major sources of radiation?
Outside of sort of nuclear stuff where things go sadly
if you
wrong.
Live near a plant or there's been
it's mostly at the hands of medical professionals, right? It's the CT scanner and the PET scanner are hands down the biggest source of radiation.
What about the X-rays at the dentist when they they scurry behind the wall, put me under the lead blanket?
They're very low, relatively speaking.
Okay.
Fluoroscopy is very high. They tend to try to cover up all of you so for example, if they were doing a fluoroscopic study of your kidney because you had a stone, or if you were getting an injection into, if they were doing a fluoroscopic guided injection of one of your discs in your neck, that would be a locally pretty high dose, but they're going to cover the hell out of you elsewhere. And again, if you get one of these things, it's not the end of the world, but boy, I wouldn't want to be getting one a month. And back to the point about screening, a chest, abdomen, pelvis CT scan is probably, look, there's probably a scanner out there now that's moving fast enough that it's much lower. But I'll give you an example. Okay. Remember how I talked about we do CT angiograms on all of our patients for coronary artery disease? An off-the-shelf scanner for this is 20 millisieverts of radiation.
Okay, so calibrate me.
That's
because
40% of your annual allotment.
Oh, wow. So the medical practitioners really are the major culprits here.
That's right. So what we say is